Good morning. Welcome to CSPAR Suicide Research Spotlight Series. This is our December, our final presentation of the year, and we wanted to spend some time reviewing 2025 efforts at CSPAR that we hadn't featured in past presentations. So welcome. I'm Julianne, Center Manager here at CSPAR, social worker by training, and we have helping us today Macy. And every time we do these, doing technical assistance and making sure everything goes off without a hitch. So if you have any issues, you can chat her for some help. And uh, that's it. Okay. Okay. Before we look at some of CSPAR's work in 2025, I wanted to kind of zoom out and revisit who CSPAR is. So we were established in 2019 and we're positioned within the University of Washington School of Medicine, Department of Psychiatry and Behavioral Sciences. Our mission is to promote the recovery of individuals experiencing suicidal thoughts and behaviors and the effectiveness and resilience of the clinicians and families who care for them through co-designing research and clinical interventions, offering expert clinician training and consultation on care improvement, and listening to the lived experience of those we serve. Reflecting on this past year, our Spotlight series has featured quite a cast of folks. We wanted to give a big thank you to everybody who presented in 2025. We've covered a range of topics from recommendations for data safety monitoring boards, caring context and ecological momentary assessment studies, qualitative analysis methodology, among others. You can see this full list. If you've missed any of these or would like to revisit them, these recordings are available on our website, and Macy will plot a link in the chat for folks here live. And for today's agenda, we're featuring mini talks of other work in our center, starting with informing 988 guidelines for working with high-risk populations. We'll have Jasmine presenting on that. Annie couldn't be here today. She's sick. So Jasmine's taken that whole presentation. Then we'll hand it off to Peyton and Jasmine again to talk about a rapid group analysis process or RAP gap of participant periods without suicidal ideation. And then we'll hand it to Tess to talk about this exciting new suicide care team project and our work over the past year and what we're expecting in 2026. And then we'll also have Dr. Adam Carmel talk a little bit about an exciting new online clinician training we've been building, also happening in 2026. So with that, I will pass it off to you, Jasmine, to take it away.
Oops, sorry, I was on mute there. Thank you all. Yeah, this presentation is, well, I'm calling it Serving High-Risk Populations who Utilize Crisis Line Services. We're specifically focusing on the literature review environmental scan for the purposes of this project. And this presentation was developed by both myself and Annie, who is unable to be here today. I just wanted to start off by acknowledging that this lit review and environmental scan was conducted as a part of a larger project between the CSPAR team, which is listed here, as well as the Behavioral Health Institute team. Both of these teams are housed at UW, and we were funded as part of a larger project by the Washington Healthcare Authority with a purpose to develop guidelines to appropriately serve high-risk populations who request crisis services in Washington State. And just a little bit of background information. This project stems originally from a goal to support crisis lines in Washington State. with aligning with Washington state legislation. This legislation set the expectation um, that these crisis services would promote behavioral health equity, um, and set standards for culturally and linguistically appropriate care through the services that they provide. And we were tasked, our team, to develop guidelines and best practices to support crisis service workers and volunteers and the centers as a whole in developing some sort of best practice or guidelines specifically for when groups that are considered high risk would call or utilize crisis line services. For the purposes of our project, we did focus primarily on 988 services in Washington State. We didn't really veer into like the mobile. I know there are mobile crisis centers and other crisis services in Washington State as well. We tried to focus specifically on people who would call the 988 line in Washington State. We started off the project by selecting specific groups that we considered high risk. This was largely informed by our subject matter experts, but also what Washington Healthcare Authority felt was high risk as well. As you can see here, these are some of the communities that we looked at. It included a lot of BIPOC populations. We included firearm owners. We looked at gender, both male, female, trans, and other identities. We also looked at geographic location, rural and frontier and agricultural workers, as well as some other groups that are listed here. Um, we know that suicide risk affects people from all communities and identities, but some communities are disproportionately impacted, and that can be in different ways. Some communities are disproportionately impacted in terms of suicide deaths. Some are experiencing rising rates at a rate higher than the general population. Some are experiencing disproportionate suicide attempts. So altogether, we tried to look at which groups we could include in our review. And this is kind of what we came up with as our high risk population groups. Um, we did this because crisis line services are a critical access point for people who have elevated risk for suicide attempts and suicide deaths. And we figured it's possible that not all groups are experiencing the services in the same way. So we decided with this project that we would conduct a review of scientific literature to identify some relevant data to understand how the groups who are high risk for suicidality are currently being served by crisis line services. We also wanted to determine if there are any pre-existing best practices or guidelines for serving those high risk populations. And get a sense of whether or not there are any gaps between the research and real world practice. So we started off with conducting a literature review of peer-reviewed studies and some relevant gray literature, which is just literature that isn't peer-reviewed. Um, there, we focus primarily on crisis line youth, so we were very specific in our search. We didn't want to go too broad, especially with such a large group of people who are considered high risk. We didn't want to extend the search too wide. So we focused primarily on crisis lines. We started off thinking specifically about focusing on 988 specifically, but there was truly a dearth of literature specific to 988 and these populations specifically. We eventually branched out. So we eventually branched out to crisis lines in general and crisis services in general. These are our inclusion and exclusion criteria. We only looked at studies where the populations um, were from a member of our high-risk groups and were accessing crisis services. And ultimately, what we found is that there is truly like very limited research in this area. There is perhaps the most research or literature in this area pertaining to veterans, which have their own line or like subline within 988. There's quite a bit of literature pertaining also to LGBTQI plus communities. But as far as some of the other groups that we identified, specific communities within like the larger BIPOC population or people who have autism, firearm owners, and some of the other groups we looked at, older adults, rural and agricultural workers, there wasn't a ton of literature pertaining to, and in some instances, there was no literature pertaining to these groups and their experiences accessing crisis services like 988. So um, we branched out a little bit further to suicide prevention services in general. Uh, in the literature when pertaining to these specific groups. In addition to the literature review, we also conducted an environmental scan. An environmental scan is simply a scan of everything outside of, pretty much everything outside of peer-reviewed literature. So we looked at websites and publicly available guidelines and resources pertaining to high-risk groups. We also conducted some interviews. So we talked to some subject matter experts, including at the national level. We got to speak with someone specifically at Vibrant, which handles the admin for the national 988 line, about what they are currently doing pertaining to training and providing resources for crisis line staff when they are handling calls from people from high risk populations. What we learned from that is that they actually have done quite a substantial amount of work um, in this area as far as providing resources and training for their staff. So they've already done a considerable amount of work in this area, and that allowed us to inform the recommendations that we ultimately put into our guidelines for Washington State specifically. And then we also, as part of that environmental scan, did a few interviews with crisis staff line workers and volunteers, as well as some advisory groups. Mostly, we were looking to get a sense of their existing knowledge of working with these groups, their comfort levels, and what they felt they needed as far as resources to serve these populations. And ultimately, these guidelines led to some recommendations, or these findings led to some recommendations pertaining to how Washington state can align themselves with that legislation that I mentioned earlier. And we ultimately found that what was already being done is fairly consistent with the best practices for serving high risk populations, which is leaning into training um, and resources that focus on cultural humility for everyone instead of kind of focusing on each individual group and each individual group's needs. A training that focuses on cultural humility um, and empathy and self-reflection is the best approach when working with these groups. Yeah, and that is it for my presentation. Did anyone have any questions or?
That was great. Thank you, Jasmine. Next up, we have Peyton and Jasmine.
Okay, I'm gonna share my screen. Do we see it? Yes. Okay, perfect. Hi, I'm Peyton. I'll be presenting with Jasmine today on an analysis we did about a few months ago. We used the rapid group analysis process and analyzed participants' periods without suicidal ideation. So excited to talk about that today with y'all. Okay, my button isn't working. Here we go. Work. There you go. Okay. Um, the first slide, of course, wanted to give a special thanks to everyone who participated in the Searchlight Study because we wouldn't be able to do these analyses without them. They're truly the best. And also all of our team members who worked on the study. This was a big collaborative study. So as you can see, there's a ton of people who worked on it. So can't name everyone because I would be here for like 10 hours, but wanted to thank all of them. And also acknowledge our funder, the National Institute of Mental Health. And the content of this is us and does not reflect them. So wanted to give some background on this study. We used data from the Searchlight Study, and I wanted to plug the CSPAR Spotlight we did in September, where we talked a lot more about the specific details of the study and everything we learned, and also some preliminary results. I put a little QR code there, but Macy had already dropped it in the chat, so you can feel free to go back to that if you haven't seen it. But for the TLDR, the study was an observational study that was trying to examine people's Google search and YouTube data, if that could predict suicidal thoughts and behaviors. And we were recruiting English-speaking adults living in the United States that had a personal Google account. And yeah, so this is kind of an overview of our study. Again, won't go into a lot of details, but we were trying to recruit 1,000 adults, and we ended up recruiting 485, which halfway there, still proud of that. We recruited online using Mental Health America and a few other websites. We collected data during the baseline period back to a year, both the Google search data and interview data. And then once they were enrolled, we had them in the study for a year afterwards, and they did surveys every 2 weeks, answering questions about their suicidal thoughts and behaviors, as well as warning signs. And then we also got their Google search data at 12 weeks, 24 weeks, 36 weeks, and 52 weeks. Um, so the measures we use for this specific analysis, we are taking an item that we added to the scale for suicidal ideation in the baseline interview. We added this item, I'll just read it word for word. Was there a time in the past year when you did not feel suicidal at all, when suicide was the farthest thought from your mind? This might be during a really good stretch when things are going well, or it could be a time when things weren't going well for you, but suicide wasn't on your radar. And so the reason we added this was because we wanted to have a time, and it's okay if people didn't have it, but if they had a time in the past year where they weren't having any suicidal thoughts at all, we could compare that time period to a time when they did have suicidal thoughts and look and see if their Google searches were different. So that was the original reason why we had that. But when we actually ended up collecting the data, we noticed that there was like these kind of like rich responses from people about like what was going on during those times. Like we were trying to collect the most important thing was collecting dates for the Google data, but then they tell us like these interesting stories about, oh, this was going on then, or, I was having a holiday or something like that. So we kind of got inspired from that, which led us to a research question for this analysis. Are there common themes between participants' descriptions of their period without suicidal ideation? So I'm going to hand it off to Jasmine, and I can keep my screen share, Jasmine. So just let me know when to move to the next slide.
Awesome, thank you. So for this project and for the data, we use a process called rapid group analysis, RAPGAP for short. I don't know how much shorter that is, but it is a analysis process that is specific to qualitative data, which is typically like free response data or interview data. And the goal is to analyze that data quickly. If you know anything about analyzing qualitative data, it can take eons of time. It can take very long and get delayed, sometimes across years. To look at this sort of data. So RapGap is intended to be very quick. Our process, I think, took maybe 3 hours total to analyze the data. Um, and it's also a very easy process to learn. It's very accessible to people who have not previously analyzed qualitative data before, which was really exciting for us because this allowed us to include the members of our lived experience contextualizing panel in the analysis process. So they got to analyze the data with us as a group. Um, and they provided a lot of rich insight that allowed us ultimately to come up with some themes for that data. Um, our RAP Gap team consisted of 4 research assistants and then 3 people with lived experience. We broke into 2 groups with lived experience people in both of those groups, so a mixture of research scientists and lived experience folks. And then we transferred those survey responses to sticky notes on an online whiteboard. And then we all gathered on Zoom to review those sticky notes and cluster all of that data into themes over Zoom. Next slide. And this is kind of like a large bird's eye view of what that whiteboard looks like after we clustered all of the responses of that data. As you can see, we clustered about 406 survey responses between the 2 groups, split directly in half. And we took a couple hours to discuss as a group and kind of move those sticky notes across the board until they formed themes. Some of those themes, um, a few of those themes that came up for the both groups, which was really nice as well, as even though that we clustered them separately, we came up with very similar themes. But some of those themes included connection to others, so family and friends and romantic partners. Many respondents described those specific instances during the year or events where they got to connect with their loved ones and friends and others throughout the year as moments where they did not experience SI. Another theme was positive life events, kind of more generally, including holidays, birthdays, graduations, pregnancy. These all were common responses that came up amongst our participants as moments where they were not thinking about SI during the year. Of course, things like travel and recreation. SI was not on the mind of our participants during these times. And then another one that came up was just being busy or distracted by some of the things that come up in life, such as work and school projects. Um, that came up quite often, including uh, caring for other people who are sick, just kind of being distracted throughout the year were moments also where there was no SI in some of our participants. Next slide. And we just wanted to share some examples of responses from some of those participants of moments where they indicated that they were not experiencing suicidal ideation. So as you see, consistent with some of those things that I mentioned, going camping uh, during pregnancy, going on cruises, kind of being busy also came up a lot. And then next slide. Yeah, so the key takeaways from this RapGap process, one was that it was really fun to gather as a group and kind of sort all of the data as a group together and discuss it. We also loved that it allowed us to involve are people with lived experience in the analysis process. And we thought that they provided some really great insights into themes. And we really appreciated their perspective on the process and some of the things that were ultimately um, developed. And then also we got many themes, but some of the standout themes were that people don't experience SI when they're traveling, when they're busy and distracted by work and school projects and positive events um, that allow them to be connected with loved ones. And yeah, that's it. Thank you.
Thank you both. We have a moment or two for any questions for the last two presentations. If folks have thoughts, you can plop it in the chat or unmute. And if there's nothing, we will forge forward. And I will invite Tess to talk about the suicide care team.
Hey, let me get my little slideshow started. Okay, so hi, I'm Tess Grover. I'm a research coordinator with the Division of Population Health, who also works with CSPAR and the Suicide Care Research Center. And I'll be presenting on our suicide care team planning grant today. So this is our lovely team. I won't go through in super detail, but these are all the people who've been involved in this one-year planning grant. And thank you to Julianne who's here and Keeney who's here. And we also have an advisory board that's comprised of clinicians, researchers who have experience in suicide care, and people with lived experience who help inform the project. So the underlying philosophy behind the suicide care team and why this was formed in the first place was the idea that suicidality presents only intermittently in healthcare. So doctors aren't always accustomed to seeing it or knowing how to respond, but if they do encounter it, it requires a very rapid and effective response. And in many cases, that response is to just send people to the emergency department, which is not always the best pathway for most individuals. And then the other sort of way to respond to suicide and suicidal ideation is that we know that there are a number of evidence-based treatments that can actually resolve acute suicidality in about 4 to 12 weeks. But there are also many complex and underlying issues and diagnoses that also need to be treated alongside the suicidality. So one of the standard approaches to forming suicide care teams is that there is a general initiative to train all healthcare professionals in suicide care. The advantage to this is that it makes sense for everyone to know how to do this. They will encounter it at some point in their clinical experience. And as I mentioned, it's a required expectation of Washington State that everyone does receive training in suicide care. However, there is the level of suicide care training that people receive is highly variable. There's not always good information about risk stratification and safety planning, so they just get sort of the basics, but not necessarily how to do a really good job of it. Doctors don't encounter this every day, so because they don't regularly practice these skills, they may not have a great deal of competence in this. There's often little to no follow-up after screening and assessment, so someone gets screened positive, they get a safety plan, but then they get no follow-up whatsoever. There's also the need for immediate care when, unfortunately, if you have to refer a patient to specialty care for suicidality, it can take weeks or even months for them to actually receive an appointment with those services. And then repetition of questions without follow-up can lead to a general distrust of health providers because they'll be telling the same story over and over about why they're experiencing suicidality without feeling like anyone is truly listening to them. So another approach, and this is what's going into the suicide care team, is the idea of just developing a specialist team. And this would be an expert team that can take referrals, provide assessments, create a treatment plan for the patient, and implement that treatment plan. They can also refer to higher levels of care as appropriate and would then offer aftercare and connect back to the original referring team after the patient receives services. And so with those two approaches, the first approach, the train all health professionals, is something that we've already been working on within Kate's two centers, SCRC and CSPAR, where we're doing a lot of studies that relate to outpatient settings. The primary care doctors are providing some of the interventions, or they're getting the interventions from a clinician that's within that setting. But what we're doing in this project is developing that specialist team. So basically, the Four Pines Fund, I don't know, a year and a half ago or so, approached Kate with this idea of, if you could do anything to improve suicide care, what would you do? And she came up with this idea for a specialist team to address this gap in care that many patients are receiving. So this is our timeline. It's a bit interesting because this is not a research project. It is a situation where we have a 1-year planning grant to actually create a proposal and an idea for this team, with the intent that the final deliverable for the project is to submit the proposal, which is where we're currently at. We are writing the proposal this month with the hope to submit in early January. And after that, ideally, obtain 3 years of funding to do a demonstration project of this suicide care team. So some of the pieces and pathways that we're thinking of with the suicide care team, and the main focus is this demonstration project that's 3 years. It would be centered at UW and would receive referrals from across the UW system. And this would be funded by Four Pines Fund. We are also looking at a study through AFSP to optimize and study the best treatment packages to use within that suicide care team. And then something for the future is we'd like to create a resource suicide care team that can serve rural or underserved health systems. And either maybe we're thinking of it as like maybe our clinicians could actually find a way to practice within those settings, or maybe we just train and support and provide resources for those settings to expand the suicide care team model. And we don't have that one as clearly defined, and we're not sure who the funder would be, but we've been talking with various other philanthropic funders for that work. So this main demonstration project that ideally would start in March if we get the funding is to launch a UW-based real-time multidisciplinary team that can respond immediately to referrals of suicidal patients from across the entire UW healthcare system. And that is including, at this point, the wellness folks who support the employees and staff, and the campus folks who get referrals from the crisis center there, or Husky Assist, which is a program with the Seattle PD that just recently started for helping to provide behavioral health support to people who call the on-campus police in crisis. And then this team would also be able to offer evidence-based treatment and care navigation to patients. So the main components that we're thinking of with this team is that there's the option for the warm handoff of care. So someone would be able to contact them, whether it's through the EHR or a phone number or what have you, and directly do a warm connection between the patient and the suicide care team, so that they identify a patient who is acutely suicidal, needs care now, and they can just immediately contact somebody to do an intake, to talk to them, to set up a next appointment. Which leads into our next, and one of the largest services that will be offered is we're hoping to be able to provide next day appointments of evidence-based psychotherapy to patients so that they don't have to wait, months to get an appointment with a specialist. There's also a consultation service we're kind of modeling after, or even working with the psychiatry consult line, where doctors or other people across the system would be able to call in to someone with expertise in suicide care and ask questions, so that if they wanted to continue treating the patients themselves, they could just get some more input. And we'd also be offering PHQ-9 surveillance, where the suicide care team would go into the HR, look at elevated PHQ-9s, and make advisements around maybe this is a good patient for referral, or what should you do about an elevated PHQ-9? Is there appropriate follow-up? So turning this into like a nice little diagram, you can see on the left, we have all of the different potential referral sources that we're thinking of. So the primary users would be what I mentioned with the wellness folks who do employee and student wellness, the counseling center and other campus people, specialty mental health, primary and urgent care, and other medical specialty settings like diabetes clinics and what have you. And these are the folks who would be able to directly use the warm handoff of care to get a next day appointment for a patient. They would be using the consultation service, and we'd be providing the PHQ-9 surveillance for them. We also have this other bucket that's more the inpatient unit and the emergency department, which we don't really see using these middle services as much. But if they have a patient in need of a next day appointment for evidence-based psychotherapy, we're thinking that they could refer directly into that service because that's not something that like the ED can normally provide. So one of the other components we're trying to think of in this proposal is a way to make this sustainable over the 3-year period of the demonstration project. So the plan that we currently have is that in year 1, the entirety of the project would be covered by the grant funding so that we can actually set up billing and services and better understand what the staffing needs are. And year 2, we would switch to having 66% covered by the grant and 33% covered by UW Medicine directly. And year 3, it would be 66 covered by UW Medicine and 33% by the grant, with the idea that at the end of the grant, we'd be a fully sustainable program that can just keep going based on billing revenue and other funding. And so what we're trying to build into this is how to bill for the service effectively, and also if there are any other operational opportunities for FTE coverage, like for example, with campus, we know that there's a student fee that is used for various activities and healthcare stuff. And maybe we can tap into that. So we're still working through the full financial sustainability, but creating a gradual model for achieving that. And then some of the other elements that we are thinking of is we're hoping to build a dashboard and other reporting tools into UW Epic for tracking on suicide metrics. And some of this may be outside of Epic too. For example, wellness and campus don't necessarily use Epic, they use other services. So having something that they could access would probably be helpful. And we're looking to other systems like Fred Hutch and Verna's work with Zero Suicide and St. Luke's and Anna Raden over there to try and get ideas on how their dashboards work and copy that. We're also hoping to develop training materials and resources for both supporting the model at UW and expanding outside of UW. So this is kind of based on the idea of how the AIMS Center works with collaborative care, where they have a lot of different resources, packages, implementation support that they can offer to different healthcare systems that want to implement collaborative care. And so we want to do something similar to that with the suicide care team. And then we also have an evaluation component because we want to know if this model is effective and actually working. And Peyton, who's on this call, but wasn't on my lovely list of team members, has recently joined to help support this and would be helping with this piece of the project going forward. And so our work to date, we've developed the strategic plan and written a proposal draft, and we're now working on the final draft of that to submit by early January. We completed 18 feedback sessions with key informants, so that were people with lived experience, clinicians who work with patients with suicidality, researchers who have expertise in this, and also leadership at UW who would be providing like the operational support to get this project going. And we've had 2 introductory sessions with this group and 2 advisory board meetings where we got input on various questions we had as we wrote the proposal. We also had a site visit with Four Pines, the funder, at the end of October, where we shared a proposal draft and most importantly, spent an entire day the day before doing a clinic tour where we had a person from UW Advancement walk the project officer around to the Ravenna Clinic to see how BHIP worked there and what the need was. Took them on campus and talked to various people who would be using this service so that they could understand what UW is and what those referral sources would need. And we also submitted our treatment component proposal to AFSP on the 5th of this month. So my last little bit is to mention what that study is. So this is the piece I mentioned earlier where we want to study the best treatment package for the suicide care team, and we'll be using the MOST framework for that. And so the treatments that we're looking at as these would be the next day evidence-based treatments that we'd offer would be collaborative assessment and management of suicidality, or CAMS, brief cognitive behavioral therapy for suicide prevention, or BCBT, family intervention that's modeled after SOARS, which Molly Adrian has been working with in Seattle Children's, and two-way caring contacts. And this study would be completed outside of UW with the WPRN and the Campfire primary care networks, which WPRN is kind of in the Pacific Northwest region, and Campfire is based in Colorado. And if that is successfully funded, which we should know in March, it would have a start of summer 2026. So yeah, and this is just the acknowledgements. Thank you to everyone who's been working on this project. We really appreciate the support we've been getting. And just a reminder that this is funded by Four Pines Fund.
Thanks, Tess. That was great. I plopped in the chat a flyer we have that kind of summarizes the suicide care team functions and vision. It doesn't describe everything that Tess just described about the planning grant and what's coming, but thought that might be helpful for folks too. And oh my gosh, we're right on schedule. Everybody's doing so good with their timing. For the next presentation, I'd like to invite Dr. Adam Carmel to talk about one of our new training projects or products, I guess, that we're going to be offering.
Hi, folks. I'm excited to be here. Would it be helpful if I kind of drive the PowerPoint bus, or would someone like to do the honors?
If you could drive, that'd be great.
Sure. Okay. So, let me share screen and off we go. Well, you can see the smiles on our face, assuming you can actually see it. Can everyone see it? So this is Kate and I holding up the published manuals for DBT Next Steps, the skills training handouts, as well as the clinician's guide. And these treatment manuals were a product of over 20 years in the making of Kate's work with the Harborview Mental Health and Addiction Services DBT team, with a lot of consultation from Marshall Linehan in UW Psychology over the years. There was a feasibility trial in the mix, as well as a multi-site reevaluation across 3 sites to kind of guide the empirical support for DBT Next Steps. And then the manual comes out after all that work, and there's lots of smiles on our faces. This picture is also really symbolic as well, because it was taken at the full day retreat that we had over the summer, where Julianne and Peyton were both present. And I'd say the 4 of us are really building this training program from scratch, right? Really a lot of close collaboration between the 4 of us. And so it was on that date in the summer where we really put our heads together to figure out how can we take these treatment manuals forward and build a Canvas-based training program for clinicians that wanted to learn the treatment, or for interested clients to get a glimpse of DBT Next Steps, figure out what it's all about, build some resources onto Canvas for those clients that would be interested too. And having resources both on Canvas as well as the CSPAR website. And so that day in the summer really kind of guided this whole project, which is in the making, which I have a few slides to tell you a little bit about. Let me back up and talk to you about how the purpose of DBT Next Steps is a bit different from the purpose of standard DBT, right? A lot of clinicians that are operating a standard DBT program work with folks that are chronically, acutely suicidal, right? High utilizers of a lot of mental health services, emergency psych services. Yet at the end of a year of standard DBT, oftentimes clients might be stable. Yet, are they really living a life worth living? Which is the goal of DBT, right? Oftentimes the question is no, right? There's stability, yet there's not that experience that clients have of reaching their life worth living goals. And this kind of tension between kind of wrapping up a year of DBT and not quite having the life that you want was really what prompted the development of DBT Next Steps. And so the question we're asking with our program is how can we support clients that are stable, right? Yet they haven't reached their social goals of building a community, building meaningful relationships. They haven't developed self-sufficiency. And almost more importantly, haven't developed financial independence goals, aren't working the careers that they want, aren't able to achieve the school goals that they want, stable, yet a significant amount of fear, really limiting their opportunities and their advancement to build the life that they want. And so the program is about building towards life ambitions. And DBT Next Steps is a advanced program for standard DBT where we're really building on a lot of strategies, mainly exposure strategies, to expand the new settings that clients are in without just kind of a lot of fear tripping them up from approaching those settings. Contingency management strategies are built into our program, and a whole new set of skills to really address the skills gap that a lot of clients have when they're trying to kind of enter or re-enter the workforce. How to be able to be interpersonally regulated, emotionally regulated, in really demanding settings. And so, thus, the goal of DBT Next Steps is an expansion of first year DBT, but we have somewhat of a unique approach in kind of building in that direction. And so our online training program is really in the service of the mission of DBT Next Steps is how do we support clinicians that are targeting in their DBT work, building a life worth living, kind of beyond the crisis. So DBT is one of many empirically supported treatments that, there's a host of online training programs to support the dissemination versus in person. I don't think DBT is unique in that realm. I think a lot of EBPs have kind of transitioned over to an online training program. So we're one of many, right? But with the manuals being published for the first time in over 20 years of research and clinical kind of integration, it really asks the question, how can we design the optimal training program to disseminate DBT Next Steps training for clinicians that want to learn it, integrate it into their clinic? And so what we found is that from our work with the annual comprehensive dialectical behavior therapy training that Kate and I co-direct at the University of Washington Department of Psychiatry, what we have with that kind of standard DBT model is levels-based training for the residents and UW staff that might have particular levels of interest, right? Like, why not cater to specific levels of interest like we do with our DBT seminar, where maybe people want to attend for a day or two and learn the components of DBT, or maybe some people want to stay for the skills, but really gearing the training towards all the different levels of interest is something that we've really valued with our standard DBT training that we've been operating for years here at UW. And so we took that same sort of philosophy into building this training and offering different levels where clinicians in the international community can sign up to attend, right? Some clinicians might just be interested in learning our unique novel skills, and that's it. And so we're building this course such that they can sign on for level one, yet maybe other clinicians want to learn all of the components of the treatment, all of the strategies, the change-based strategies, how to do individual DBT next steps versus the skills operate largely from a group model. Level two is there for those clinicians that want to learn that, right? Versus level three is more about program implementation considerations, how to run an optimal DBT Next Steps program that's full fidelity to the model. Yet I'm guessing a lot of clinicians won't be asking that question. They might want to just dip their toe in the water, learn skills, and sign off. But for those that want to build a comprehensive training, level three is there to support them in moving that forward. And then level four is building on that even more. How can we support clinicians that want to learn everything that we're offering and come together to be part of a forum or discussion board? We want to offer recorded role plays, more specific consultation, and then program consultation to support them with their implementation barriers. So I'm just appreciating other presentations in this hour around integrating people with lived experience into the model. It's a natural point for us to do that in DBT Next Steps. And maybe this speaks a little bit to the DBT Next Steps model, that oftentimes we're looking for opportunities for clients to integrate into the group and practice kind of like leading certain components of the group, steering some of the aspects of the group. Because if they can practice leaning in and kind of jumping into a group and steering some of the process, that's only going to give them practice as they set forth and approach their career goals. Why not practice it in group with us so they can stand the best chance of showing up professionally with a lot of interpersonal skills out in their world? And so with that model, right, that a lot of DBT Next Steps groups take that kind of spirit forward, we thought it would be really beneficial to integrate people that have lived experience even into the training program. So that led us to decide to invite a collaborator who had lived experience of going through standard DBT as well as a Next Steps program and have this person do question and answer and interviews of Kate and I. and have those interviews be the thing that we're posting on our CSPAR website once they're finalized. So it's really sharing information about the training program and the context of how DBT Next Steps was developed, but through the lens of a client with lived experience, right? Rather than just having it be Kate and I talking. What an amazing opportunity to have someone that has flourished as a result of this program, steering the conversation, asking the questions kind of through their lens, so that clients that might want to kind of get a little bit of a flavor of DBT Next Steps and see the kind of free videos that we're going to offer on CSPAR, they can have the person with lived experience guide the conversation. I know we're almost out of time. Last slide is just talk about next steps for DBT Next Steps training. We're in the process of building it, right? Right after this call, we have a recorded kind of role play of a mock group. We thought the best way to kind of train folks in running the group is just to see mock role plays of a therapist with a mock group in action. So they can kind of like learn as they go rather than just didactic training. We thought it would be more engaging and illustrate the concepts more to kind of build, kind of like watch a group in action. So we're building training and hope to launch the full course through Canvas mid 2026. And then the ongoing offerings are the level 4 trainings, which will be the forum for discussions, a lot of programmatic support, and kind of ongoing role plays that we hope to offer. I think I'm out of time, but I'm wondering if there's room for questions, first of all.
Yeah, we have a couple minutes. I'm not seeing any in the chat and no raised hands.
Well, it's been a pleasure getting to stop by and talk a little bit about this project, right? And given that it'll be kind of through CSPAR, available with Canvas through UW, we'll make sure to alert folks when the training is live and welcome any sort of questions or follow-up thoughts after this presentation.
Wonderful. Thanks, Adam. All right. Well, thanks everybody who presented today. It was kind of cool to see the range of work CSPAR's been doing outside some of our big research studies. I just wanted to pull up on the screen our 2026 Spotlight schedule by hitting the right buttons and zoom. So coming up next year, we will be continuing this Spotlight series that happens third Thursdays, 9 to 10 a.m. Pacific, 12 to 1 Eastern. And we're trying to organize our talks around a specific theme. So the theme we chose for 2026 is the different faces of suicide prevention and recovery. Registration is required for these talks. You all know since you're here. And I have on the screen here our January, February, and March topics. So in January, we have Dr. Ashley Hageman from the Yale School of Public Health talking about decolonizing suicide prevention implementation work, strategies for crisis planning among diverse global populations. And then in February, we have Carolina Velez Grau from the Boston College School of Social Work talking about ethnic identity and other cultural aspects associated with suicidal ideation and global strategies to increase access to care and reduce risk factors. And then in March, we have Dr. Lauren Kazem from the Ohio State University Wexner Medical Center talking about increasing the efficacy and accessibility of suicide prevention for the disability community. We hope to see y'all there. I think in the chat, Macy's going to plop a link to an evaluation and the registration links in the chat. so that folks can click on those and get there. Beautiful. And we hope that everybody has a lovely end of the year and happy new year. And we'll see you then. And if there's any questions, we'll hang out here for a couple of minutes before we close the line. Thank you, everyone.